I'm Helen Serrana. I'm one of the editors at BMJ Future Health. Thank you to everyone who is in the process of joining us for this BMJ Future Health webinar. I think this is number 3 this year, but there's some coming up every month. So really excited that this webinar is called Digital Frontiers in Paediatric Care, Innovation, Inclusivity and Patient Empowerment. And we've got 3 excellent speakers coming up. The format's going to be a quick 10 minutes from each of them in their area of specialty. Then we'll have a discussion amongst the panel, and as we go along, please put your questions in either the chat or the Q&A box, and I will bring those questions into our panel discussion. And towards the end of that, any further questions there are, I'll put to the panel at the end. So I'm delighted that we're welcoming Professor Paul Dimitri from the University of Sheffield, Professor Susan Shelmerdine, who is the Royal College of Radiologists and Great Ormond Street. And later on, we'll be joined hopefully by Dr. Venkat Reddy from Peterborough. But first of all, I'm going to hand straight over to Paul, because you're going to give us your talk, sets the scene really and what's going on in the systems in this country around paediatric innovation. So Paul, over to you.
Helen, thanks very much for your kind introduction. So I am just going to share my screen now and just check with you, you can see it okay. So hopefully that's visible to you now.
Yes, perfect.
Marvelous. That's great. Well, thank you very much. First of all, thank you very much to BMJ for inviting me to the BMJ Future Health webinar. And as Helen's already said, excuse me, I am here essentially to set the scene around child health technology and where the challenges are, but the opportunities with the infrastructure that we have to support child health technology. So first of all, and this is the leading statement, and this is the most important statement to begin with, and there's an important statement at the end, is that children are 25% of the population. They are 100% of the future. Whatever we do now with our health and healthcare will have a lasting effect for the next 100 years. A child that's born today has the potential to live up to 90 years old. So if we get the health and healthcare right through technology and other means now, we have the best chance of supporting their health in the future as adults and having a sustainable healthcare system. But we have some challenges ahead. First of all, one of the challenges is scale. Pediatrics is a large specialty, it's a big population, as I've just said, but trying to get technology into a system for children and young people is really quite challenging. And that's partly linked with the investment issue, is that those that wish to invest in supporting child health technology are not seeing the opportunity for scale. So it's hugely important that we work as collaboratively as possible and in consortia to make sure that we offer scale and opportunity for those that wish to invest in child health technology to bring it to fruition and get it into the hands of those that need it. Then there's the issue of diversity and adaptability. In pediatrics, we work right the way from preterm babies through to adolescents who are 16, 17 years old, some of them fully mature. And you've got to be able to adapt those technologies for the needs of the children and young people that we look after, but also to think about the autonomy side, which is that parents look after the technologies to begin with, and then as children get into adolescence, they need to start looking after the technologies and using them themselves. So there's a lot of variability in the technology we develop. There's data privacy and consent issues around data. We have to think about age-related health literacy and how that works in the digital landscape across those multiple different age groups. And then finally, one of the things that worries many people is this issue of long-term impact of technology use with children and young people. Are they using too much technology, and do we have to also think about tempering it in healthcare as well as in their social lives as well? So in terms of where we started as a network, we started in 2014. I brought colleagues together from across the country, really to think about how we work in that consortium approach that I was talking about previously, where we can collaborate to provide industry and investors with something scalable to invest and support child health technology development. We started the TITCH network, Technology, Innovation, Transforming Child Health. We had a £50,000 investment from the Yorkshire and Humber Academic Health Science Network. And from there, through understanding unmet needs from workshops and working with funders, we leveraged within the space of 3 years, £6.2 million of funding for child health technology. And of course, with that, there was only 2 of us working in this space at the time, bringing colleagues together and establishing that network. We got very busy. So we applied to the NIHR, National Institute for Health and Care Research, for funding to become one of 11 medtech in vitro diagnostic cooperatives. And we were successful in that funding. We received £1 million of funding that ran over 5 years. And again, we took that consortium approach. There were 7 centres. The NIHR SIP Medtech, Children and Young People Medtech Cooperative, was hosted by Sheffield, but with 6 other centres that were working with us collaboratively. And over those 5 years, we were successful in a number of areas. We were successful from the educational side. We supported 13 PhD students and hosted early career researchers. We worked on 180 projects, 56% of which included an industry partner. And importantly, from the work that we did, we held conferences, we published papers, as you can see the figures there, but we leveraged £17.1 million of funding that included that TICH funding as well. But for industry, by working with them, they also went on to leverage a further £27 million of funding to develop child health technologies. So this was really a rapidly growing area, an area that's really ripe for investment and opportunity. During this time as well, we also hosted the UK's first Child Health Technology Conference, and I think one of the first in the world. That was back in 2021, and we've kept that conference online for a reason, which is to create a global child health technology community. So we have had speakers and delegates from 33 countries. We've had 170 speakers and 607 delegates. And we really, truly have a spirit of collaboration across multiple different countries, but also through that conference, we have a very heavy focus on patient-public involvement and engagement, really around about inclusivity and engagement. And we're hosting the next conference in June, so next month. That's Child Health Technology 2025. So I would encourage you to go online. The web address is there for the Child Health Technology Conference and sign up. It's a 2-day conference. I love the conference. So of course, I'm biased, but I love the conference because there's so much diversity in terms of discussion and technology there. So please sign up for the conference. So moving on, the NIHR Children and Young People Medtech Cooperative, the contracting lasts for 5 years. So the NIHR then advertised for new centres called Health Tech Research Centres. There are now 14 of these Health Tech Research Centres funded and supported by NIHR across the country, of which we now have received funding to develop and host the NIHR Health Tech Research Centre in Paediatric and Child Health. And you can see from the map there, again, it's totally collaborative. We've got 5 different themes, 3 themes with 2 cross-cutting themes, all hosted by different centres in the country there. So we've got early life, which is preterm babies and neonates. That's hosted by Professor Don Sharkey at the University of Nottingham, Queen's Medical Centre in Nottingham. Long-term conditions in childhood, which incorporates rare diseases, hosted in Sheffield, but also co-hosted by my colleague Helen Storr, Professor Helen Storr in Great Ormond Street Hospital, hosted by Professor Heather Elphick at Sheffield Children's Hospital, and Dr. Renuka Diaz in Birmingham Women's and Children's Hospital. Then we've got mind-body integration, which is about the interface of physical and mental health and how we integrate those collectively within technologies, hosted by my colleagues at the University of Cambridge, Dr. Kathy Beardstall and Professor Paul Fletcher. And then Chain, which is
I'm just checking to see, it is Paul who's frozen, not just for me, isn't it?
Yes, I'm still here, Helen.
Oh, great. Let's see if Paul recovers. And the internet from Sheffield is not necessarily as great as we could have hoped for it. But Susan, it's great to see that you're already here. Oh, look, that looks like is that Paul's desktop? Susan, how ready are you to go? Fairly ready?
Yes, I'm ready to go. I'm happy to share my screen if that would be helpful.
Yeah, that would be great, actually. So if we carry on, and we'll come back to hear the end of Paul's presentation after we've booked our appraisal, which he's insisting we do at the moment. But if we could, yes, I'm seeing your screen now. Sorry about that. So let me introduce Professor Susan Shelmerdine, and you've got a slightly more specific thing to talk to us about paediatric imaging. So over to you, Susan. Thank you.
Thank you so much. It's a pleasure to be here. And thank you to everyone who's online right now. I'm Susan Shelmerdine. I'm a consultant radiologist specializing in pediatric imaging. And I'm going to talk to you about a very specific use case, which is fracture detection using AI on imaging. Why this problem? We heard from Professor Dimitri about how we want to be scalable, we need big data, and we want something that's a relatively common problem that's going to have a huge impact for children for the long term. And I believe fracture is one of those things. Across the country, across emergency departments, I don't know any that hasn't seen a child with a fracture, because it is estimated that about a third to a half of all children will break a bone at some point in their childhood. They're very, very active and engaging little members of society, and they are pushing the boundaries of what they can do. As I've said before, it has implications for long-term growth and disability. If you fracture through a bone and it goes through a growth plate and it doesn't heal properly and it wasn't picked up and it wasn't treated, you might have long-term problems with walking, for example. And also, very importantly for child health, if that fracture was due to suspected physical abuse and we missed that, that fracture might not kill the child, but sending them back to an environment that's unsafe because you missed that opportunity for safeguarding probably could kill them. So it's hugely important to pick these up. But as we know, children's bones are different to adult bones. They break in different ways and they look slightly differently across different age groups. And these fractures can be subtle. It's estimated that about 10% of emergency department staff miss them. And that's not because they're bad, but they are busy, they are disrupted, they have lots of things going on. And also, you know, I'm in a position of privilege as a radiologist with my dark room, big high resolution monitors, but that's not the case on the front line where maybe your screens aren't particularly high resolution, so subtle things get missed. So the answer is, could AI be the answer to that? Could we start picking up fractures better with that? The body of work that I've been funded through the NIHR to do down in London has been to explore whether or not this is something we can do that will make real world impact. So earlier on this year, we published a paper which was a systematic review looking at what kinds of AI technologies were there for imaging to detect fractures on children's bones. And we found that there were 26 eligible studies in the literature, of which 17 really were published in the last 2 years. So that's just showing you how much of this is all happening very recently. And whilst many of them do exist that are, you know, talking about diagnostic accuracies, actually, a lot of them are not ready for commercial use or deployment. About 4 products do exist for commercial use for children for fracture detection. And of those, there are 7 articles talking about their clinical validation. Accuracy rates are variable. They're pretty good, 85 to 100%, but that is still a big range. And what we really want AI to do isn't to replace humans, but to assist us, to make us even more better than we are already. And only 6 articles really tried to show whether or not we could work together with the AI in a more symbiotic way, rather than just the AI acting alone. And of those 6 articles, 2 showed that humans with AI did show better improvement than just the human working on its own. And that was 2 that showed it was statistically significant. So I mentioned earlier that we have lots and lots of different fracture subtypes in children, some of them more relevant to long-term disability than others. Does AI help us in that? Well, there's not a huge amount of evidence for this in general. And I think rather disappointingly, it seems that of the few studies that have looked into fracture subtypes and whether AI helps with any of those in particular, the ones it tends to do worse at also happen to be the ones that we as humans tend to find a little bit harder to pick up. I know as a radiologist that avulsion fractures can be subtle, and the AI also, for example, in the first study here, is less accurate at picking those up too. And also we know elbow fractures can look very subtle. Sometimes you don't even see the fracture line. And you can see in the second study here that actually looking for joint effusions and dislocations in the elbow area can be less accurate than in other types of fracture types as well. So what does that leave us with? Can we actually work well with the AI? Does it help improve us if we're also bad at picking up the same things it's bad at picking up? Well, that does sound a bit disappointing, but evidence, the limited evidence we have from our systematic review does show that actually it does help humans, but only very specific subsets of humans. And that subset includes those who are less experienced. For example, in one study by Nagoyan et al., they showed that radiology residents were more likely to improve their diagnostic accuracy when they had AI assistance. But really experienced radiologists, it had no impact on them whatsoever. So if you were going to implement an AI in a department where you've got very experienced people, that could be a waste of money and might not necessarily help them. But if you had more of a mixed group or some who were very junior, it might be more helpful. So we're still trying to figure out that human AI collaboration and who does it work for and how do we work together. Currently, I'm in the process of analyzing a huge data set of this kind of human AI collaborative work. We published a protocol in the BMJ Open last year where we wanted to look at which humans, not just radiologists who are junior or senior, but emergency staff, orthopedic surgeons, reporting radiographers, nurse practitioners, anyone who would be tasked by looking at a child's X-ray on the front line, who would improve more. And in this simulated study, we've got 156 readers who have completed both rounds of this project. Round one was looking at 500 images on their own, and round two was looking at the same 500 mixed up, but with an AI to assist them. And also asking them, would you change your management plan for this patient? Because ultimately, whether or not you're more accurate or less accurate, it might not make a difference if what you were going to do for the patient is the same, right? From a sort of patient outcomes point of view. Of course, it matters from giving reassurance and having an answer for something, but we also really wanted to know, would the AI actually change things in the future? This is still a simulated study, and of course, we do need more real-world studies, and I'll talk a little bit about the gaps in the evidence shortly. One of those big gaps is looking at specific types of children who have rare bone diseases, for example, osteogenesis imperfecta. At Great Ormond Street, we are a centre that sees quite a lot of these children, but it's not the only rare bone disease. There are a multitude of other metabolic bone diseases as well that predispose children to fractures. But we did a small little study trying to do an external validation of a commercial AI product that looked for fractures on X-rays to see whether or not that would translate into X-rays of children with these rare bone diseases, OI, I said earlier. And what we found was the AI did perform worse in these children compared to what the vendor publicized it would work on, say, children without these rare bone diseases. The accuracy was 74.8%. However, when we looked at humans alone looking at these X-rays, they were slightly more accurate. When I say humans, I mean radiologists who are trained or fellowship trained in pediatrics. So they were at 83.4% accurate in picking up these fractures. However, what was really surprising to me was working together, they were more accurate than either of them alone, which I think is quite a strange thing, because a lot of the studies I read, the AI is hugely accurate, the humans are sort of similar, and then together they're better. But here the AI was much worse than the humans, but it still helped them. And the reason for that in this particular small study was that the AI was undercooling and our humans were overcooling, and together they sort of balanced each other out. So it shows there's no real one size fits all. It's kind of trying to understand, where do we implement this to get the best use out of technology and our own human expertise. And of course, we need to know the pitfalls from this AI. Just because we do it in one group of patients doesn't mean the same pitfalls will be in another. And here I'm showing you an X-ray of a forearm in a child with osteogenesis imperfecta, and the AI has erroneously put a little box around an area it thinks might be a fracture. And that isn't a fracture, that's just an area of intraosseous calcification that you can see in these particular children, which is quite a quirk of that disease. And obviously the AI hasn't seen this before and doesn't know. So I talked about where we are, and now I'm going to talk a little bit about the missing gaps in our evidence and where I think we're going to go with this. So I had the privilege of being on a specialist committee member for the NICE early evaluation assessment, looking at AI technologies for fracture detection on imaging. This wasn't child specific, but it did include children as well as adults. And you can see here on the left, there's a lot of evidence generation that still is needed. Although we do have 4 commercial products, which I'm showing you in the table on the right here, you can see the boxes in which the NICE committee felt they needed evidence for. A lot of them, it's limited evidence or no evidence or ongoing evidence, and we're not quite sure. But some of these areas that are of big concern are, does it really change service outcomes? Is it effective in different subgroups? Are we biasing against certain populations, children being a big one of those? And what are the costs and the return on investments? And how do we make this an economically sensible thing to do? And the other touch point I would just like to mention, and I'll show you a picture later, is a very interesting point here. I've talked about fracture detection on X-rays for limb fractures, but of course you can see other things other than fractures on these X-rays, right? It's not just a binary yes, no fracture, no fracture. There are other things such as dislocation, effusions, bone tumors, swellings, arthritis, things like that you would also see on X-rays. And we don't have a huge amount of detail on whether they are good or bad or able to detect these other kinds of diseases, or whether having an AI that says yes, no fracture means we stop thinking and we don't look for what else it could be. And that's an important point that not many people have looked at. So essentially, missing gaps include prospective real-world trials with actual patient outcomes, health economic modeling, whether or not this changes what staff do as a result of this job, or this task being semi-supervised or outsourced to the AI. And also, I mentioned earlier about abuse and physical abuse, and we're still exploring whether or not AI can be used for that kind of medical legal aspect of it. So I'm just going to show you, I mentioned earlier about, can AI pick up other things? Will it stop us thinking? Here's an X-ray of an ankle of a child, and it doesn't have a fracture. And the AI to the right has shown no output because it doesn't see a fracture. However, maybe some of the more astute of the audience can spot this little lucent lesion on the talar dome, which is highlighting an osteochondral defect, which can be a cause of pain and suffering for the child, as well as swelling and disability. But if you're very convinced that, you know, I've got an AI, I'm looking for fracture, no fracture, and the AI says nothing, therefore there's nothing there, will it stop you thinking about other possibilities? We don't know, but clearly it's something we need to think about when we integrate into our workflow and clinical practices. So in the last few minutes, I'm just going to highlight a little bit about the PPIE work and what we do going forwards. We obviously know there's no point using technology if our patients don't like it and don't accept it. So I've done a bit of work asking children and their parents and carers how they would like AI to be used, especially for fractures as a use case. And one of the members of our patient public group helped co-write this paper with me and is the leading author here, which is great to have their input on this. This is a very busy slide, but what I just want to hammer home is the bar charts that show dark shading are where people agree or strongly agree. And the ones that I've boxed in red are where they find they feel most strongly about these statements. And overall, in children, and this was about 170 children we asked across age groups from 6 years old to 22 years, they really highlighted the need for transparency. They wanted to be asked permission and given consent when AI was being used. It might not always be possible, but at least they wanted to know and be involved in that discussion. They prioritized accuracy over efficiency and speed, and they really wanted a human in the loop checking the AI outputs. However, one interesting part of this research was, whilst they said they wanted a human in the loop, they also mostly agreed that in the future, AI might replace some tasks that doctors do. So whilst they recognize they would like a human, they also know that that might not be possible going forwards. And that's, I guess, still something we're trying to understand. Where is it appropriate? Where is it not appropriate? And mostly parents thought the same as their children. We also asked almost 150 parents and carers what they thought about this. And they had very similar aspects in terms of permission, consent, accountability. But what was different between the parents and the children were that parents were more likely to believe that AI could be very helpful. They thought it was going to be more accurate than children thought it would be accurate. But they were also more worried about the risks of data falling into the wrong hands, of privacy, of where this was going, how it was going to be used, cybersecurity issues. So that was some kind of difference there. And I guess that would feed very much into when we choose our messaging and our wording and our consent when talking to families about the use of AI in the children's healthcare. And then just the last few slides now, what I'm also very interested in is, you know, just because we can say we see a fracture or don't see a fracture, we see a problem, does it actually mean we do the right thing to fix that problem? You know, I'm sure many of us in our own lives have seen problems happening, but we don't necessarily do the right thing about them, do we? Or we ignore them, or we overreact to them. And the same thing can be said about fractures. So thank you to various different people, orthopedic surgeons who have shared these images with me, where they've shown actually children who break the bones and in some very horrifically displaced ways can actually be managed quite conservatively without necessarily any big surgical intervention, and come out with pretty nice looking bones that have healed in a very aligned way without having to go in there and do operations on them. So actually, we don't really need to interfere. And if we have an AI that's saying there's a fracture, do something about it, will we be tempted to do the wrong thing or over-treat them? And so one thing that we're working on right now at Great Ormond Street is to see how much of this pathway we could automate using AI technologies. Instead of just looking at the fracture, which is in the middle here with a box around it, can we be more specific about what kind of fracture it is? And can we include evidence-based practices to nudge people towards doing the best thing, which is maybe supportive management in some ways rather than intervention? And then potentially even generating from AI a personalized patient care letter about how you manage your fracture at home, or maybe a draft letter to the GP saying what's happened about it and what the doctors think about it in that consultation in the emergency department. So how much of this can we process? This, again, is still under development and under research, and we are doing quite a lot of PPIE work on this. But the future can be limitless, and there are many things and creative things we can do with AI. So my final message to you is, despite having more AI tools in imaging than any other subspecialty in healthcare, despite fractures being a really common problem across patients, there are still huge gaps in what we can do and what we know and what we think about how we integrate this into clinical practice. And the answers are by no means sorted out yet, and it's still all for us to discuss as a group, but it's pretty exciting and I look forward to the discussion. I've put my QR code there for my LinkedIn profile if anyone wants to get in touch with me, and I look forward to the questions shortly. Thanks so much.
Brilliant. Thank you so much, Susan. And because we've just lost a bit of time, and then earlier we lost one of our speakers. So I'm going, before we come to Dr. Reddy, I'm going to just go back to Professor Dimitri. Paul, I'm really sorry, we did lose you. Are you able to share your screen and just finish off your talk? I understand you've just got about 5 minutes that you've got further to share. Are you on mute, Paul?
Sorry, can you see my screen now?
I can see your screen and I can hear you. Thank you. Over to
That's
you.
great. Well, so apologies to the audience. So it's always ironic that in a presentation on technology that the technology goes wrong. And so anyway, such is life. And thank you, Susie, for filling in while I was sorting out the technology here. So I just finished off. I was talking about the NIHR Health Tech Research Centre in Paediatric and Child Health of 5 different areas: early life, long-term conditions, and transition, with 2 cross-cutting themes: mind-body integration, which was the interface of physical and mental health within technologies, and then the child health artificial intelligence network, which is around how we use data within devices and how we use algorithms and how we generate an output that is meaningful for healthcare professionals, children, young people, and their families. With the HRC and Paediatric and Child Health, we do a lot. We work with industry around early engagement and co-design, which includes a lot of PPIE work on the principle of health technology designed for children, with children. No technology, or every technology, I should say, that we develop has input from children and young people. We work to a commercialization framework. We have a lot of infrastructure and expertise to support industry partners. We have lots of networking and showcase opportunities, and we leverage the wider NIHR ecosystem because we are incredibly well connected across NIHR and across Paediatrics and Child Health. We also have an education platform which supports a PhD program with 11 PhD students about to start in the forthcoming year. We've got multidisciplinary and supervisory teams for those students and others working in the field. We have an Elevate to Innovate training program, which is being developed at the moment, which is a physical and web-based program for webinar-based opportunities and visiting opportunities as well. And we run an accelerator, the first one, which is just run from October 24 to February 25, which brought 12 companies through, 10 completed, all getting commercialization, business support, and clinical support as well. And importantly, there was a young person's panel telling those companies what they felt was appropriate for the technology from a young person's point of view. That is the most brutal part of the accelerator, is listening to the children and young people telling you exactly what does and doesn't work. So that's the timeline from 2014 to 2024. In 10 years, those networks have developed. Now the NHR Health Tech Research Centre and Paediatric Child Health, from a £50,000 investment, we have leveraged £50.2 million of funding to support the development of child health technology. So that's not a bad return on investment from £50,000. And just lastly, to talk a bit about the National Centre for Child Health Technologies. So this was an idea that I had in 2016 to build a physical centre that would bring together industry partners, healthcare professionals, universities and academics, and most importantly, children and young people, all in the same centre, focusing on the development of child health technology. And the idea is really to create the best and most advanced healthcare technology in the world to be spread across the UK and internationally. This is being built at the moment. It costs £24 million to build, and in size is 42,000 square foot. It will be based at the Sheffield Olympic Legacy Park, in which there are other infrastructure there that support physical health and well-being, moving more elite sports education with 2 schools next door with 2,000 students on site. We'll work collaboratively with to support the development of these technologies, and then importantly, other private sector partners such as Canon Medical, who have located there with an imaging centre there as well. And we're building now. It's great to see the building. We started building on the 20th of January this year. There are diggers in there. I've never been so excited to see diggers in all my life. And we're hopefully going to be opening the doors in 2026. So we look forward to welcoming our colleagues across industry, the universities and clinical areas, and again, most importantly, children and young people to be working in the centre. We'll be basing our strategic objectives around the government priorities for the NHS as they stand at the moment: analog to digital, treatment to prevention, and moving care from the acute setting to the community setting. And just lastly, not just talking about Sheffield, but some other key infrastructure that are supporting technology development both nationally and internationally. So we work very closely, apart from our partners in the Health Tech Research Centre and Paediatric Child Health, we work with Great Ormond Street Hospital with their Drive Innovation Hub, which is really very focused and highly expert in the use of data and the development of AI algorithms. Our colleagues at Alder Hey Innovation at Alder Hey Children's Hospital in Liverpool that do very similar things around device and web-based technology development. And then we work nationally with groups such as the Health Innovation Network. We work very closely with Health Innovation Yorkshire and Humber in Sheffield, but there are other health innovation groups as well across the HIN network. We have the Children's Hospital Alliance, which is a consortium of 14 different organisations who were working collaboratively to really address that issue of scale. How do we scale up technology quickly across multiple different hospitals? And we also work with and in the Royal College of Paediatric and Child Health. We've started up the digital committee over the last 18 months. We're working on developing digital skills platform for paediatricians and members of the Royal College of Paediatrics and Child Health, and also a digital solutions catalogue, which focuses on digital solutions that have worked in other trusts that we can showcase for other organisations to pick up and use to have impact in their own organisations. And then from an international perspective, there are other infrastructure. There's KidsX, led from the US, which is primarily US focused, but does have an international reach as well. There's i4Kids, which is based in Barcelona in Spain, which are doing a lot of work to support countries that are less well developed in technology infrastructure. And then there's ETRI, the European Paediatric Translational Research Infrastructure, of which I lead the medical devices thematic research platform, which is again bringing together European and also Israeli colleagues together to support technology development. So I said I would leave you with a key message at the end. So I said 25% of the population, 100% of the future at the beginning. This is my last key message, which is start early, change more. Whatever we do, whether it be technology or anything else, if we start early and we start early in life, we can afford ourselves the best change for many years to come. So we must invest more focus, time, research, and technology, as well as money in child health and healthcare to support the best health and healthcare for the future. So ladies and gentlemen, thank you very much for your attention. Sorry for the technology glitch in the middle, and I will pass back to Helen now, and I look forward to the Q&A session as well. Thank you.
Brilliant. Thanks so much, Paul. That's fantastic. And because we're running a little short on time, I'm going to hand straight over to Dr. Reddy. Venkat, are you ready to share your screen?
I am, Helen. Can you?
Fantastic. Yeah, and I can see it. Over to you.
Excellent. Let me.
I'll be taking questions for everyone at the end, so please put your questions in the box as we go along, and we'll hopefully have some time at the end.
Right. Can you still see me? Can you hear me,
Yes,
Helen?
I can see and hear everything. That's perfect.
Fantastic. I'm just moving the pictures around so I can see. So thank you so much for inviting me. And I'm so glad to be following Paul, because literally 2 out of 3 things I do is with Paul. And first and foremost, I'm a neurodevelopmental consultant pediatrician in Cambridgeshire and Peterborough NHS Foundation Trust, which covers 2 extreme diverse areas of Cambridge and Peterborough in terms of demographics, socioeconomic status, languages spoken, and deprivation. And I've been trying for the last 25 years, clinically in leadership, innovation, clinical research, and through digital tools last 5 or 6 years to improve the care of children, young people with neurodevelopmental conditions and disabilities. I also work with Paul as Officer for Digital Health and Technology at the Royal College of Paediatrics and Child Health, and also with Paul at the NIH Health Tech Research Center for Pediatrics and Child Health. And I'm the theme lead for the education and the training. And Paul was talking about Elevate, Innovate, and web-based programs. I'm leading the development of that. Oh, slide is moving. I just want to declare some conflicts of interest, because I also work with private enterprise and some startups. And these are the 4 I have worked in the past, but I no longer work with any of them. But I provided paid advice, and mostly in the field of developing both clinical and family portals to integrate data to support children with the disabilities and long-term health conditions. And QB Tech was a national clinical lead for the implementation of a focus ADHD program, which rolled out the objective measurement of ADHD symptoms across the NHS. And I worked with a biomarker-based ADHD company, Illyria, all in the field of neurodevelopment. So what I'm going to talk today, very briefly about autism and how we recognize, screen for, diagnose, and treat, how we did it pre-COVID, and what we did it during the COVID when we had to digitize very rapidly, and finish up with some promising developments of utilizing artificial intelligence and the digital tools and the platforms to bridge that gap we have. There's a huge increase, exponential increase in recognition and referral and need for assessment for all neurodevelopmental conditions, including autism. We do not have enough trained expert clinicians anywhere in the world. Forget about low and medium income countries, even in high income countries. And there is a digital, and AI has a role to help us to bridge that gap a little better. So for people who are not clinically aware of what autism is. It's a neurodevelopmental condition that primarily affects communication, both verbal and nonverbal, social interaction, and presence with restricted and repetitive behaviors. And there can be a lot of co-occurring conditions like intellectual disability, ADHD, anxiety, and higher incidence of physical problems like epilepsy. The current pathways or pre-COVID pathways tend to be a referral would come in from a health visitor or a GP or a school nurse or a special educational needs coordinator. A lot of information and a lot of questionnaires are collected that is looked at by a community pediatrician for preschool children or a pediatrician or a child psychiatrist for the school age. And there will be a multidisciplinary team assessment with psychology, speech and language therapy, occupational therapy, mental health nurses to pull together all that information and do a structured assessment of social communication. Often we use a tool called Autism Diagnostic Observation Schedule. We also need to look for any associated physical health conditions, genetic conditions. Then all that information is looked at together in a multidisciplinary team. A formulation is arrived at. It's not just good enough to say it is autism or not. We need to develop the full developmental profile of the child, their strengths, their needs, and co-occurring conditions, and that will inform a detailed support and treatment plan. Then we need to sit down and explain that to the child, if old enough, and the family, so that we fully bring them on board right from the beginning, because this can be a life-changing event in a child and family's life, and this affects them, their education, health, and the care, and the lifelong implications. So 2020, coincidentally, I was doing my PG diploma in NHS Digital Academy. I was cohort 3, and that time COVID hit. And I used the digitization of autism pathway as my work-based project, as well as my MSc dissertation. I looked at digital tools for early recognition of autism. So very rapidly, we have to digitize. What I described before is to be everything done in person, and often would take 3 or 4 appointments to the clinic to make a diagnosis and then to provide feedback. So very quickly, some elements of digitization was fairly easy. So information collecting, questionnaire gathering, we digitized it very quickly. And a video consultation platform like Attend Anywhere by phone or by video consultation, we could take all the developmental history, family history, and social history. The 2 elements which were almost most difficult to digitize, the first one is that structured autism diagnostic observation schedule, which happens in a room with very specific toys following a very specific prompts, and it's often administered by a trained administrator like a speech therapist or a psychologist or a mental health practitioner. It's a video recorded. There is a second person coding in the video recording room, and a consensus is arrived. That is quite difficult to do with the face mask on, because we're trying to objectively assess verbal communication, non-verbal communication, social interaction, watching for restricted, repetitive, stereotyped movements. So there was an attempt to turn that into a digital assessment, and that BOSA, Brief Observation of Symptoms of Autism, which is very similar to the Autism Diagnostic Observation Schedule, was developed very rapidly, where we would send the toys and the instructions to the family, and they would do that administration at home, and the 2 clinicians would watch it live on a video platform. We also tried actually asking parents to play at home, but record it and upload it into our video platform, and then we would asynchronously code it and try to make same assessment and come to same conclusions. So no good doing all these assessments. I'll tell you a little bit of, so it worked well, but there is always problems. digital poverty. So a lot of families in Peterborough, some of them didn't have a desktop or a laptop or a iPad, even phone's a problem. We have to send some SIMs, and some families are really reluctant to let the cameras into the homes. So there's a digital poverty that affected. So English is not the first language. It's impossible to do that. And imagine trying to keep a 3-year-old, especially probably autistic child who has got very strong preferences, to do what we want them to do, stay in focus for the video recording, for us to be able to watch and code that. That was quite tricky, but we could probably get it right in about 60 to 70% in straightforward cases, but we couldn't rule it out as confidently as we could rule it in cases where there's very obvious autistic symptoms and the signs. So there's no point doing the assessments unless we could actually deliver therapy during the COVID. And there's a fantastic evidence-based intervention called Pediatric Autism Communication Therapy, which is very simple. We train already trained clinicians like speech therapists and psychologists to teach parents how to play with the children at home, video record it, upload that video, then the professional and the parent together watch the video, and the professional will guide the parent through the how to change their own communication behavior, socialization, and the play to cue into the child with autism who has got atypical way of communicating, socializing, and playing. So this is all parents acting as a therapist, and this was delivered through the video facilities as well. We did a local evaluation, which came out really, really well, enjoyed by the parents, good improvement with outcomes, and it will be fantastic to roll it out, but it costs a little bit more than what we're providing at the moment. To take it one step further, one of the problems is that often we don't get referrals for preschool children until 3. That means that we're losing that incredibly plastic brain period of development during the first 1,000 days. So we need to get in a little bit earlier. So there are some tools where we can start surveilling and screening for social communication difficulties from 12 months onwards. And a slightly modified version of that pediatric autism communication therapy could be utilized without waiting for the diagnosis. That has a major impact in positive development of communication, social interaction skill. If anything, the need for MDT assessment goes down. This being rolled out at the moment in Greater Manchester, it would be a fantastic way to screen early, intervene waiting for the diagnosis, and teach parents how to support the children. So other tools we used during that period, so that surveillance I talked about, a lot of autism screening tools start about 3. They tend to be the same. They're questionnaire paper-based or digitized. Parents find it quite tricky to identify whether the child's eye contact is typical or atypical, the turn-taking or pointing. So in Australia, they developed a social communication surveillance tool, which is digitized into an AS Detect app, which is free for the parents to download. And given for the age of the child, parent will be shown a typical video and an atypical video of the important features of autism, like eye contact, and parents will select whether the child is presenting with typical eye contact or atypical eye contact. Very quick questionnaires after the video, and that will give a likelihood of low, a medium, high likelihood of autism. By utilizing that, we used to have the problem of some of our clinicians who are not experts. They're quite scared to mention autism because they don't want to get it wrong, and they don't want to alarm parents until the symptoms are very prominent and very easy to detect. By utilizing that, parents can have a printout and take it to the health visitor or a GP to say, look, it looks like this. Can you make a referral? Or even more importantly, we can start providing that iBasis VIPP program without waiting until the symptoms become so obvious that can be diagnosed or needing a diagnosis. So now it's a little bit of AI because we want to finish on that one. As you can imagine, what people are looking to do is can we replicate that utilizing machine learning algorithms really? So this is commercialized in USA, has got FDA clearance. This is the first FDA clearance. So what happens here? Parents video child for about 5 to 10 minutes, upload into a video platform, and you can train non-experts like a GCSE student or A-level student to watch the video and answer those. You can see that they're rating the social interaction excellent, good, poor. Those features are extracted and they were features were selected and they were run through different types of algorithms, and they selected the best one which performs well, which has got a sensitivity of 95% and specificity of 78%. So that's been commercialized, but still being used as a diagnostic decision aid rather than a human is still in the loop and the MDT assessment is still needed. Next, there's a lot of research going on. So the first one we talked about, we still need those two applications, still need humans to extract the features and put them into the algorithm for it to give a recommendation. There are a lot of attempts going on to automate the whole process. So this is a paper talking about recording conversation or a speech and putting it through a classifier, and it can detect the patterns of volume, intonation, and rhythm and the rate. And it achieved an accuracy rate of accurately identifying about 87%. The second one is I talked about stereotyped motor movements, and that can be due to a lot of other reasons. But there is another mechanism of videoing these movements, then using a convoluted neural network to see if they're typical of autism or the typical of epilepsy, or that could be due to other movements, and it achieved accuracy about 92%. So we're looking at non-verbal, verbal, restricted, repetitive, and stereotyped movements separately at the moment. So then I want to come to, that's all far out in the future. What can we do within here and now with the data we already got, really? And this is the data from Bourne and Broadford project, where there's a lot of routine assessment of children's development happens. Health visitors start at 12 months, and they use a questionnaire for parents called Ages and Stages questionnaire. As soon as the child starts in education setting at the age of 3, then there's something called early years foundation stage profile, education developmental profile, looking at gross motor skills, fine motor skills, social skills, learning, and there is a score is given. And using that retrospectively, and if that score is below 25, there is very high chances of that child getting a positive diagnosis of autism. And if that actually can be used prospectively, it goes up even higher. The most important factor which was realized in using this prospectively is that these children who are flagged up for assessment using this tool were the ones often missed by the humans, and they often tend to be girls and the children from the ethnic minorities. So this is one example of actually where AI can actually help us to reduce those inequality and and that's because girls with autism present differently, and if a different language and different way of interacting, you can miss that as well.
Venkat, we've just got 1 minute left, please, so
Yep,
we can have a bit of time for questions.
This is the last slide.
Fabulous.
Yeah. So to take it one step further, in Cambridge, Dr. Anna Moore's team in our child and adolescent psychiatry department, we're beginning to build a child and adolescent data resource, which will be able to pull in routine data from education, health, and social care. First, we're looking to build an AI tool to recognize mental health problems early, and we will move on to the neurodevelopmental problems next. So the last slide is that this is all good at the front end, but without a very good back end, it all takes a long time. So having a very good electronic health record, with the patient portal where people can upload all those videos and the documents, and using an ambient AI scribe, which we are trialing at the moment, then able to automate the process afterwards about requesting investigations, generating letters, and booking follow-up appointments. We will be able to streamline the whole process much better and reduce that huge gap between the demand and capacity at the moment. Thank you so much.
Brilliant. Thank you so much, Dr. Reddy, and all three of you for joining us. I think we've had three really fascinating and pretty in-depth presentations that span a huge range of issues in paediatrics, so and digital health. So in terms of questions, there have been a few, and Paul, I think you've been fairly active sort of answering those fairly straightforward ones, but I just to ask you all quickly to talk a little bit about the issue with patient involvement in research with children, because we BMJ were very passionate about making this possible, but it often comes up as a question as how do you do it with kids? It must be hard. It's hardest to do it with kids because they don't know what they're talking about. So I just wanted a quick comment from each of you about sort of maybe a quick tip for if you haven't involved children in your research about children, what's the best way to start?
So can I maybe start on that, if you can hear me? That's good.
Please.
Okay. Yeah, the bottom line is I would sort of dispute that. I don't think children are hard to work with at all. I think they're actually very easy to work with. You just need the right approaches. So if you remember during my presentation, I said we do everything about technology that we develop. We involve children and young people, because fundamentally, if you don't involve children and young people in the development of those technologies, the risk of it failing goes up significantly. So it's hugely important to incorporate the voice and views of the end user through technology development to increase the chance of success. So we do through the NIHR Health Tech Research Centre in Paediatric and Child Health. We will be through the National Centre for Child Health Technology. And in fact, every other infrastructure network that I've led, we do a lot of work around code design and code development with children and young people. We have those with the right expertise to work with groups of people, both locally and nationally, to make sure that the voice of children and young people is heard. It's fundamental in this and in research as well. There's a phrase that's been adapted: no research for us without us. We can use the same technology. No technology or no health technology for us without us. So yes, we have the right people in place. Our PPIE executive lead, Jennifer Preston, works at the University of Liverpool. She's done a lot of work around methodologies, frameworks, and approaches to working with children and young people to develop technology.
Brilliant, thanks.
Come in, Helen, if you want me to follow. Yeah. So I think one of the Royal College of Pediatrics and Child Health, we also have a Children and Young People's Forum. It's called And Us. And they have developed something called a Recipe for Involvement. And there is a whole range of tools and activities and exact practical tools about how to use different ingredients and different ways of engaging children, young people, and families of all ages to be able to do that. So I'm very happy to send you a link to that to share with people, really. And also I'm part of digital design group. We are building designing Cambridge Children's Hospital to be built. And we have excellent examples of utilizing children and young people in every aspect of designing the whole of from the building to digital infrastructure to research. And the last one I talk about the cadre, and we also got a children and young people's group advising about even if we can recognize mental health problems early with existing data, is it a good thing to do? How to do it sensibly, what they would be happy with, and what would worry about, as Paul mentioned and Susie mentioned earlier about the transparency, consent, and involvement right from the beginning, human in the loop, that comes up again and again, really.
Brilliant, thank you. Susan, have you got anything to add quickly to that?
Yeah, I would just say at Great Ormond Street, we also have a young persons advisory group as well as a parent and care advisory group. And I don't think it's fair to say that children don't understand it. I find them actually, they understand far more than many clinicians I speak to, and they are digital natives and they come up with very, very considered views. So I agree. I think the beauty of AI is that it's not just a tool, but it's forcing us to look at our social values and how we become more inclusive of everyone in our population. And a final point I just want to mention is that do bring them along with you on the journey, co-creation, co-design, bringing their thoughts into it. You'll be surprised by some of the imaginative ways they come up with. If anyone is interested in children's views on AI, not just in healthcare, but generally, I would really urge you to look at the Alan Turing Child AI consortium and website. They did a huge piece on a child AI summit this year and presented it in Paris at the AI Safety Summit. And you can see some of the views that children have on AI in general if you're interested in that.
Yeah, just on that note, Helen, sorry, I'll put in a link in there is a framework for the use of AI that's been proposed in MPJ Digital Medicine called Accept AI. So I'll put the link in the chat there. It's a very helpful framework.
I'll allow it, even though it's a nature journal and BMJ. I'll allow it. Thank you so much. Look, we haven't got much longer. Charlotte, have you got the finishing slides? There's just a few things I wanted to share quickly with you if you're still here. We're part of BMJ Future Health event, which is happening in November. So registration is now open for that. One of the things we're wanting, so there's a QR code you can scan there, or you can go to the Future Health website. There'll be loads more talks like this with loads more time to talk about these talks and meet with people. So do join us for that if you can. We do start from problems in health tech. We're not coming with solutions to everything, but we want to hear everyone's problems. So rather than a call for abstracts with people shouting about how great their ideas are, we want to hear what the issues are that we think health tech can solve. So this, it would be great to have a really strong paediatric section of problems to look at and unpick at that event, which is going to be really educational. And I think that's it from us. Yes, the next webinar, of course, coming up at the end of this month. We've got 2 in May, so that's brilliant. Making innovation your specialty. Those of you who are interested in health tech innovation as a career, it's not easy path to forge at the moment. So grateful to our speakers who are forging that path for many of the people coming through, but that would be a great webinar at the end of this month. So it's just left for me, we've gone 2 minutes over, but I think you will allow us that because it's been such a fascinating session. Thank you so much to all our speakers. Really appreciate your time and your expertise, and I'm sure you're happy for people to contact you if they've got further questions. So thanks very much, and tell your friends that they can watch this website again on watch this webinar again on our YouTube channel or on the Future Health website. So it will be up to watch again for everyone if you want. That's it. Thank you. And feedback poll. Tell us what you thought as well. We're always interested. Do fill that in before you leave. Thank you very much, everyone.